Hi, I'm Mark Zadie, and I'm a graduate student in the Waters-Korzynski group at the University of Toronto, here to present my work on computational staining of tumor hypoxia from H&E images using convolutional neural networks. Low oxygen, termed hypoxia, arises from decreasing oxygen levels as you go further away from vessels or the transient occlusion of them. Molecular oxygen drastically improves the efficacy of ionizing radiation. Therefore, hypoxic cells confer a resistance to radiotherapy. And furthermore, biochemical pathways become altered to promote hypoxic cell survival. In order to image hypoxia proliferation gradients, several immunohistochemical markers are used. We can use EF5, which is a marker of hypoxia, EDU, a marker of proliferation, CD31, a marker of vasculature, and Hurst, which has been used as a marker of perfusion. Hurst, in conjunction with CD31, can be used to delineate between chronic and acute hypoxia. Based on the spatial colocalization of the perfusion marker in vasculature, we can use it to discriminate perfused from non-perfused vessels and therefore delineate chronic from acutely hypoxic tissue. Furthermore, we can measure changes in hypoxia and proliferation gradients as a function of distance from several morphological structures that are delineated during this analysis. So, from this study, we can see that hypoxia increases and proliferation decreases as a function of distance to vasculature, whereas hypoxia decreases and proliferation increases further from necrosis. What I want you to take away from this is that there are certain morphological features in the tumor microenvironment that can be used to predict hypoxia, some of which are visible on sections stained with rudimentary dyes such as H&E. And so we asked, if these morphological features are visible on an H&E, is it possible to computationally stain an image of and predict hypoxia distributions? As a result, we developed COSPRAY, a convolutional neural network for computational stain prediction. Our current multiplexed immunohistochemistry workflow includes an image of hypoxia, necrosis, annotations, and an H&E image. COSPRAY can be trained on these images and outputs a matching image of hypoxia when given in H&E sections with annotations of necrosis present. Despite training the model for a relatively short time, we were able to get a very reasonable prediction with an average mean square error of only 1.2%. To further illustrate this rapid learning, the animation here shows the quality of predicted stain images as a function of epochs. 241 epochs equate to roughly 50 minutes of training. And as you can see, there's a rapid convergence in mean square error values in both the test and training datasets early in the training. This indicates a strong association between hypoxia and morphological elements of H&E stained images. It is important to note that there is a small but significant decrease in predicted hypoxia staining relative to the ground truth. We believe that this consistent underestimation may be due to challenges in predicting acutely hypoxic regions, which are not necessarily associated with necrosis. As hypoxia confers a resistance to both radiotherapy and chemotherapy, numerous clinical studies have shown a strong association between hypoxia and poor patient prognosis. Failure to control for variable tumor oxygenation can negatively impact a clinical trial due to repopulation and metastasis of surviving hypoxic cells. Since hypoxia probes may not have been administered to patients and limited tissue availability can limit the retroactive analysis of unsuccessful trials, COSPRAY serves as an invaluable tool for indicating whether tumor hypoxia may have modulated treatment response. So, to summarize, hypoxia has been shown to confer a poor patient prognosis, and we have observed associations between hypoxia and morphological structures within the tumor microenvironment. As many of these structures can be seen on H&E stained sections, which are ubiquitously used in medical diagnosis, we have developed COSPRAY, a computational tool for predicting hypoxia distributions in H&E sections. We believe that this tool can be used in the retroactive analysis of clinical trials, thereby furthering the development of adjuvant hypoxia-targeted therapies. And finally, I would like to thank Hao-Sin Tsui, one of the key developers of COSPRAY, as well as Dr. Trevor McKee, Dr. Bo Wang, and Dr. Bradley Waters. Thank you.